Awesome.
We are recording.
Thank you. Hi, everyone, and welcome to Living Beyond Breast Cancer's continuing education program for Living Beyond Breast Cancer leadership volunteers. My name is Erin Alum-Hansen, and I'm the Director of Outreach at LBBC. And I have the pleasure of serving as your moderator for tonight's program. Tonight, we have members of LBBC's leadership volunteer community joining us from across the country. This includes our young advocates, Hear My Voice, community connectors, and helpline volunteers. So we love these continuing ed opportunities to kind of bring all those fantastic groups together across our broad Living Beyond Breast Cancer leadership volunteer community. We want to do a special welcome to our newest cohort of leadership volunteers, the 2021 Hear My Voice advocates. We're so happy to continue to expand LBBC's leadership volunteer community with our 8th class of Hear My Voice advocates, especially during this time of uncertainty and challenging times with the pandemic. You know, we really feel the call even more for advocacy, support, and community. So we're so thrilled to be in the middle of training our newest class of Hear My Voice volunteers. We started things off last week, and we'll be picking them back up with our live training next week. So during tonight's continuing education webinar, we're going to focus on health disparities and issues of health equity impacting the breast cancer community. Tonight's speakers are Jasmine Souers and Marissa Thomas, who are both Young Advocate alumni. Jasmine and Marissa are founders of For the Breast of Us, whose mission it is to empower women of color affected by breast cancer to make the rest of their lives the best lives through education, advocacy, and community. So before I introduce them, just a few reminders and housekeeping tips. Again, if you could mute your line and turn off your cameras during the presentation. We recommend if you go up to the right-hand corner of Zoom and select speaker view, that would be a great way to really focus on the speakers as they're giving the presentation. And then at the end, we will have time for Q&A at the end of the program, and you're welcome to ask any questions throughout the program in the chat box. We will hold the questions to the end, but if you think of a great question and want to put it in the chat when you think of it, please go ahead and do that. And then at the end, we'll have time for verbal questions as well, and we'll have you unmute yourself at that point. So if you have any technical issues during the program, please let us know in the chat box and we'll try to assist you. And now I want to just introduce Jasmine and Marissa. So Jasmine is a breast cancer survivor from Jacksonville, Florida, who was diagnosed with stage 1 breast cancer at the age of 26. Jasmine believes in the power of sharing the voices of women from marginalized communities to break barriers in the cancer community. Jasmine was trained as an LBBC Young Advocate in 2019. Marissa was diagnosed in November 2015 at the age of 35 with breast cancer. While in treatment, Marissa turned to social media as a way to connect with other women and find similar stories to her in the hopes of making the journey easier. Marissa's passion going forward is to help anyone who comes behind her and has to fight this horrible disease, focusing primarily on women of color, educating them on navigating the healthcare system and defining life after cancer. Marissa has also been trained as a LBBC Young Advocate in 2019, and she recently joined LBBC's Board of Directors. So I'll turn things over now to Jasmine and Marissa for the rest of the program.
Thank you so much for that introduction. I will go ahead and share my screen.
Thank you, Erin. Good evening, everybody. It's so nice to see everyone.
Let's go here. And are you guys, can you see our presentation, Marissa? Yeah.
Yes.
Alrighty. So as stated before, my name is Jasmine Souers. I'm co-founder for The Breast of Us. Marissa is my work wife. And tonight we're going to be talking about how to be an accomplice to women of color affected by breast cancer. So at the very basics, our mission and kind of what we do, as Erin stated, our mission for the Breast of Us is to empower women of color affected by breast cancer to make the rest of their lives the best of their lives through education, advocacy, and community. We are a blog, and our blog provides tools, resources, and community to help women of color overcome the barriers to quality healthcare.
Got it? You good?
So why we're here today? We're here to build bridges in the breast cancer community, to encourage empathy and understanding among those able to assist with meaningful change, and to provide a framework to move from awareness to action. One of the things For the Breast of Us that we always talk about is that we are all definitely aware of breast cancer, but now it's time to put some action behind that awareness.
So these are our rules of engagement for tonight's conversation. First of all, we want to make sure that we want to encourage you to have empathy. You are here to learn. We are here to share our experiences and some of the research that we've done. Be ready to feel uncomfortable or feel triggered by things that you may learn or hear. Be willing to take yourself out of the center. Listen with intention of gaining a better understanding, and be mindful of your response and be respectful, and understand that acknowledging someone else's experience, the difference in someone else's experience, does not negate your experience at all.
So who are women of color? Black women, of course, are considered women of color, but the term women of color is an inclusive term for all non-white women. When referring to a specific race of women, use the name of that specific race of women. So African American or Black, Asian, Native American. Only use the term women of color when referring to more than one minority group.
For many distinct groups or individual races, when you use the term women of color, when you're really trying to refer to a specific group, it's kind of seen as an erasure, and it can be seen as offensive. So the terminology, let's talk accomplice versus ally. So in the simplest form, we borrowed the term from the LGBTQ plus community. And our understanding was that an accomplice, an ally stands with you when an accomplice gets their hands dirty in the fight. And very recently, the Anti-Racism and Social Justice Library, or at Pitt Libraries, they released this definition. And they said all accomplices are allies, but not all allies are accomplices. While an ally is willing to stand in support of marginalized voice, risk is rarely involved. An accomplice uses their power and privilege they have to challenge the status quo, often risking their physical or social well-being in the process. So caveat, we're not asking anyone to throw themselves in front of a bus, right? But when we talk about risking social well-being, the accomplices that we've been working with in the community, the women that are actually doing things that are creating change, when they go in to push on behalf of representation of other women of color, that is a risk to their reputation. So it is a little bit more engaged, a little bit more active than being someone that just understands and thinks that it's a great idea to have representation.
Yes, one of the things that we say is an accomplice is somebody who's going to roll up their sleeves and get dirty in the work with us. So systemic racism in healthcare. Systemic racism or institutional racism, which I'm sure a lot of us have heard in the news recently, refers to how ideas of white superiority are captured in everyday thinking at a systems level, taking in the big picture of how society operates rather than looking at one-on-one interactions. It is the biased societal approach to housing, education, employment, healthcare, and criminal justice. Individuals may not see themselves as racist, but they can still benefit from systems that privilege white faces and white voices.
So a couple of examples. One of the examples we give all the time is I was diagnosed in 2016, and going through my mastectomy, the first thing I did was go to Google because I wanted to see what Black women look like with mastectomies. And all the images were above the fold. And most of the images that had anything to do with Black were Black and white images of white women. So then I had skepticism. I wanted to know why I couldn't find imagery of Black women with mastectomies. Was I being asked to do something that other women weren't being asked to do? Who has the bad doctor was what came to my mind. Something as simple as being able to find imagery, it can aid you in your treatment process because now you have a better idea of what to look at. And that's not something that you can control if you are not a woman of color, but that representation is something that you would benefit from. That makes sense.
Yep, exactly.
Root of the problems. So many disparities in health are rooted in inequities and the opportunities and resources needed to be as healthy as possible. The detriments of health include living and work conditions, education, income, neighborhood characteristics, social inclusion, and medical care. The strongest predictor of health and socioeconomic status, the strongest predictor of health is socioeconomic status, and socioeconomic status is the social standing or class of an individual or group. This is often measured as a combination of education, income, and occupation. Examinations of socioeconomic status often reveal inequities in access to resources, plus issues related to privilege, power, and control. So while financial stability is considered the fundamental cause of health disparities, the association between socioeconomic status and health is dependent upon race. So what they do when they look at health disparities often is when they solve for education and income, the disparities are often still very persistent.
Mm-hmm. A history of misconduct. So before the Civil War, medical experiments were commonly conducted on free and enslaved Black bodies, dead or alive, without consent. Between 1845 and 1849, Dr. Marion James Sims, the father of minor gynecology, guinea pigged 3 Alabama slave women to pioneer a new procedure. Each woman underwent up to 30 painful operations without anesthesia until Dr. Sims succeeded, after which the physician proceeded with the procedure on white women with anesthesia. Throughout the 1800s, scientists from both the medical community and the greater university community published scholarship supporting theories of white supremacy and scientific racism. Between the 1930s and 1970s, 1/3 of Puerto Rican women of childbearing age were sterilized, many under coercion. Likewise, in the 1960s and 1970s, thousands of Native American women were sterilized without consent. And in California, eugenics law forced and coerced thousands of sterilizations of women and men of Mexican descent in the 20th century. This is how, if you think about why some medical providers, even now to this day, say that people of color, or specifically even Black women, we have a higher tolerance of pain. This is where some of the root of that comes from. So it's not actually a medical fact or a scientific fact. It's just something that's been passed on through. And you can see people talk about it even now on Twitter, medical people who are just residents who say, oh, I didn't think that that person needed any pain medication because I was told that they have a higher tolerance of pain.
You also have research studies showing that even though Black patients will report having higher pain levels, they are often likely less treated than their white counterparts. And the other things we want to demonstrate with this history of medical mistrust, when we talk about women of color, we are talking about marginalized communities that have experienced misconduct at the hand of our country, and that extends beyond Black women, or Black people rather. And then some of the most public cases are going to be things like the Tuskegee Experiment and Henrietta Lacks. So the Tuskegee Experiment, and this is something that I don't think people really realize, is that the Tuskegee Experiment really ended in 1972, and that's really not that long ago because my mom was born in like 64, 65. So the Public Health Service tracked about 600 low-income African-American men to Tuskegee, Alabama, about 400 of whom had syphilis. They stated the purpose was to better understand the natural course of the disease. To do so, the men were lied about the study and provided sham treatments. Many needlessly passed the disease on to family members, suffered, and died. And the impact of that did last a couple of generations. And then you have Henrietta Lacks. In 1951, an African-American woman named Henrietta Lacks was diagnosed with terminal cervical cancer. She was treated at Johns Hopkins University, where a doctor named George J. snipped cells from her cervix without telling her. For more than 60 years, lac cells have been cultured and used in experiments ranging from determining the long-term side effects of radiation to testing a live polio vaccine. Her cells were commercialized and have generated millions of dollars in profit for the medical researchers who patented her tissue. The thing that we want to pull everyone's attention to is when we start to talk about representation in clinical trials, skepticism, and mistrust. These are very public cases. But even though we have these examples of very high profile cases, research is still showing that though we are very underrepresented in clinical trials, there is a willingness to participate if educated properly.
So breast cancer health disparities. I'm sure a lot of us have seen this flyer. It's definitely posted on social media, or you may have gotten this flyer at any of the conferences that you went, but it's from Story Half Told. And it's talking about a disease with disparities, which is breast cancer, which a lot of us have heard in the news recently. While death rates are decreasing across ethnicities, and ethnic disparities still exist in breast cancer care and prognosis. So for African-American women are on an average 40% more likely to die of the disease than white women with breast cancer, and are 2 times more likely than white women in the US to develop triple negative breast cancer, which is associated with poorer prognosis. Hispanic women are more likely than non-Hispanic white women to be diagnosed with tumors that are larger and are hormone receptive negative. So again, triple negative breast cancer, both of which are more difficult to treat. And then Asian and Pacific Islander women have seen their incidence of breast cancer increase steadily. In California, which has the largest Asian population in the US, the largest increase has been seen in 4.7% of Koreans from 1988 to 2006, and 2.5% in Southeast Asians from 1988 to 2013.
And the interesting thing about the mortality rate of African-American women is that the incidence rate is about the same, though the mortality rate is so much higher for Black women. Mm-hmm. And then, as I was talking about earlier, our participation in clinical trials. So I think everyone here probably understands the importance of clinical trials, and that if you're not represented, then your community is less likely to be part of the innovative cancer treatments, and the medicines aren't necessarily going to be as effective for other communities. And so when we're looking at the participation in clinical trials, 82.9% of participants are white, only 6.2 are African-American, Asian 3.3, Hispanic 2.2, Native American 0.1. So when we talk about representation, we start with, from our personal perspectives, Marissa and I started with not being able to find imagery, not being able to find stories, not being able to find wigs. But when you really start to look at the numbers, that representation is reflected throughout the breast cancer community. So as a Black woman, if you think it's difficult to find imagery of what a mastectomy looks like, imagine what a Native American woman looks like.
Right, or even just seeing, Latina women finding just wigs that is in their type of texture of their hair, or just reading about their experiences. As we know, we all have different experiences. And when it comes to family history, learning about that as well.
So a little bit more on the terminology. We are very big on the pursuit of health equity, not health equality. So, and these are kind of different. I love these pictures. I think it presents it perfectly. Equality is the assumption that everyone benefits from the same supports, and this is equal treatment. We know that, one, we haven't even gotten to the point to where we can get equal care, right? But we know that some communities are they have different barriers. And so it's going to take a little bit more to get us to a place where we are receiving the same benefits, the same outcomes. So then we have health equity, where everyone gets the supports they need, no matter how much or how little that is. But then justice is actually, this is like systemic change. That's actually removing the barriers. And a little deeper dive on that.
So the pursuit of health equity. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. So some common barriers to quality healthcare include medical mistrust, poor communication, perceived discrimination, racial discordance, and cultural differences. And the list of barriers goes on. So there's transportation, experiences based on race, income inequality, employment, implicit bias by providers, etc. So just like the last slide that Jasmine spoke on, these are some of the barriers that we have heard of in our community and around, just from social media or people that we talk to, that will stand in the way from them getting that health equity.
And I don't want to say this is cool. I'm just like, I love learning, right? Okay. So poor communication, it's not just in the way that patients talk to their doctors, it's also in language. When we are talking about, okay, so we call our community, they're called breast cancer baddies. So we'll probably use that terminology. So when we talk about our Asian baddies or our Latino baddies, Native American baddies, how much those differences in language are not only making it difficult for them to have quality health care, but it's also pushing them to other places to find information like YouTube, where the resources may not be as trustworthy. And that further creates barriers because now we have poor information. And then we're looking at experience based on race. One of the research projects that we're working on right now is looking at the impact of race and culture on the perception of clinical trial and understanding how we can, as a community, help address those different needs. When you think about experience based on race, it was really interesting because whereas we did interviews, we're getting ready to do the survey portion, but in the initial interviews, we had Black women who we already know have a very high level of mistrust with doctors, and their perception of doctors as well is mostly negative. Then we had our Asian women who are women of color, but most of them reported having positive experience with doctors, positive perceptions of doctors, and they cited that back to having so many doctors in their families. So it's those kind of nuances that really do impact the way that people navigate the healthcare system.
Right. Even on the poor communication side, if you think about whenever you are discharged from the hospital or you're leaving your doctor's appointment and then they give you the handout that explains what your discharge is supposed to be, your instructions. If you speak another language, how are you going to disseminate that information? So then you have to take it home. And then hopefully, and 9 times out of 10, it's mostly going to be one of your children or somebody younger in the house that's going to have to translate that for you. And what is the hope that they're going to translate it the way how you need it, so that way your care can continue the way how you need it to be. So that's just one little thing that medical institutions can just change. That's easy to do, but we still don't have it.
Right. So where do you come in? There are women of color who want to help change the odds for their communities, but they are struggling to be seen, heard, and valued in the breast cancer community, whether that be research, media, leadership, and other opportunities. Well, an ally is someone who stands by your side. An accomplice actively participates in the fight, and we invite those who do not identify as women of color to be a bad accomplice in our fight against the barriers to quality treatment for women of color and the health disparities they create. In order to use your own privilege for good and to be a good accomplice, you must be aware, listen, and speak up. Focus on equity instead of equality so that everyone is given what they need to be seen. So this, our initial talk about privilege, and we're probably going to get into this in the next slide, our initial talk about privilege for women of color, it's normally stems on race. But one thing that we'll talk about later is that everyone has a different privilege. So even if you are a woman of color, as a Black woman, I am an advocate for my community. I'm an accomplice to my Latina sisters because I'm not a Latina. So just because you are, so an accomplice isn't, it's not, you're not pigeonholed to just being a non-woman of color. Anyone can be an accomplice to a community that they may not represent.
So what is privilege? Behind every privilege is the imbalance of power. It's invisible to those who possess it and ever present for those who don't. Privilege describes benefits that belong to people because they fit into a specific social group or have certain dimensions to their identity. You can have or lack privilege because of your race, gender, sexual orientation, ability, religion, wealth, class, among many other characteristics. Having privilege means having an advantage that is out of your control and that you didn't ask for. You may not even notice it until you educate yourself about its existence. Most of us are privileged in at least one way. That doesn't mean we didn't work hard or that we didn't experience any other hardships in life. So I have a really good thing about privilege that I know Jasmine and I have talked about, and we've talked about it before. So not only am I a breast cancer survivor, I actually work in healthcare. I've been working in healthcare for almost about 20 years now. So that is my privilege, that I work in healthcare, and I don't take that lightly. So I know that I can navigate the system a whole lot easier than other people who have been diagnosed with a life-threatening illness. For example, as soon as I was diagnosed, I called the doctor that I work with. I told him. He called one of the best breast cancer surgeons that he knows of here in the Seattle area and got me in the next day. I know many of women who do not have that privilege to do that. So I know that that's my privilege. And again, I don't take that lightly. So what I need to do as being an accomplice is help the other women and other people who are around me get access to that same type of privilege. That's what privilege is. So privilege, like we were saying before, it doesn't matter about the color of your skin, doesn't matter about your class. Everybody has some type of privilege. It's when you have that privilege and acknowledging it and then using that to help other people gain that same type of access. And that's what we should be doing if you have any type of privilege.
Absolutely. And I think one thing that I tell people a lot is having access to like geography, where you live can be a privilege. For me, I live in Jacksonville, Florida. I have access to MD Anderson. I have access to Mayo Clinic, UF Health, university hospitals. They're all downtown. And there are other women that don't have those same access. I think as women in the breast cancer community, we can all probably say that there is definitely a gender privilege because men do not have the same exposure. They don't have the same resources as women typically do. So this is, again, looking beyond race and just understanding that all of us in one way or another have opportunities where we can use our life or an aspect of our life to help someone else.
Right. And even though, again, that I have that privilege or Jasmine has that privilege, that doesn't negate anybody else's circumstance or their journey. And it doesn't mean that when somebody says that, you know, we should like clutch our pearls and just be like, oh my God, I can't believe that I have this. It's just acknowledging that you have that privilege and then knowing what are you going to do moving forward since you have that type of privilege.
So in terms of race, definition of white privilege, in many countries, white privilege benefits white people at the expense of people of color. Lacking white privilege can include being directly stereotyped or treated differently, but it can also mean not seeing yourself represented in the society you live in. Examples, we talked about the ease of finding images and stories of other breast cancer survivors who look like you, access to clean beauty brands. They don't often extend their color ranges to women of color. The availability of cancer wigs and your hair color or texture. And one of the most stark examples is there have been studies that have shown, we talk about implicit bias, that people or doctors aren't trying to intentionally, it's not something they're doing intentionally, but it's something that has been done. And the study, they gave doctors 2 cases. And the only thing that they changed was the race of the patients in those studies. And the Black patients were said to be given less effective treatments than the white patients. And the doctor's reasoning was like, they were thinking, well, they're not going to be adherent to it. They're not going to, they have all these reasons why they didn't think that it was going to work out. But the white means that white patients are going to be more likely to benefit from that implicit bias than a patient of color.
So our Accomplice guide, we published an Accomplice guide that is on our website that we encourage everyone to take a look at and share with anyone within your community. But some of the key points of it is to follow. We encourage you to attend events, meetings, and other activities where women of color are leading discussions that impact communities of color and our society at large. Listen and ask questions. If you are looking to create a conversation about an issue or issues that have an impact on communities of color, we encourage you to bring women of color to the table and invite them to take lead in those conversations. Participate. We encourage you to engage in our community so you can support our mission and collectively work together to break down barriers to quality treatment for women of color. We encourage you to also take what you learn and share with your own friends and family and community members. Invite them to engage with our community as well. We encourage you to volunteer and lend your services and expertise to further the work of organizations and businesses supporting women of color affected by breast cancer.
So the Accomplice Guide was adapted from an organization called Women of Color for Progress, a local organization. And they had a place where people, and this was a great challenge that we had when we first created For the Breast of Us, women that did not identify as women of color, people that did not identify as women of color, they wanted to know how they could help. And so we adapted that guide to fit specifically for this. But Marissa and I, as both early stagers, these are also the things that we do when it comes to being an accomplice to the metastatic breast cancer community. I think so many times people just want to say, I just want to know the numbers and I want to go and I want to spout the numbers to people. Being an accomplice isn't about just having the information, being able to retort it or to restate it to people. It's more about lending your privilege or your opportunities, your access to allow other communities to do those things for themselves. Because there are so many women of color, there are so many women in the metastatic breast cancer community, even if you're being an accomplice to men, there's so many men that are very educated and they are very willing and able to advocate for their communities if given the opportunity and the resources. So amplify and empower. So we encourage you to take the voices of women of color in our group into consideration, particularly when organizing your own activities in your respective groups and communities. We would love to attend, we as a woman of color would love to attend and participate in your community discussions to add another perspective so we can learn from one another. And this goes to how many panels that are happening in the breast cancer community that don't include women of color. It's what we know, what is research-based, is that women of color do have very unique experiences in navigating the healthcare system. And so when all these panels about breast cancer are happening, Black perspectives aren't being considered, it's missing a large part of the narrative. And it's one that definitely needs to be seen so that more people can help address those concerns. And we encourage you to support and promote the businesses and organizations created by and for women of color affected by breast cancer. Often women of color don't have access to the same resources as our counterparts. One of the things that have helped Marissa and I tremendously have been women that give us opportunities that we know nothing about, that we are not in those circles. And that's been one of the ways that we've been able to grow as quickly as we have, and one of the ways that we've been able to access so many opportunities. Empower. We encourage you to inform women of color of available leadership, advocacy, and volunteer positions in the cancer community. And we encourage you to connect your networks to the work women of color are advancing in the breast cancer community and vice versa. For example, when the CDC is looking for their young breast cancer cabinet, those opportunities initially came for me from other white women. I had no idea that those things were happening. I'm not in the circles where those conversations were being had. So it was someone else that said, I want to make sure that you are aware of this opportunity, that gave me a chance to be at least considered.
So the do's. Do stand up for women of color who is being discriminated against. Do call someone out for telling a sexist or racially insensitive joke. The joke might seem harmless and it would be easier to brush it off, but these little moments, also known as microaggressions, add up to something big. Do examine your own prejudices. It's important as an accomplice to face your own prejudices and unconscious biases. Otherwise, it's possible to act in ways that can be more harmful than helpful, even with the best intentions. Do continue to listen and learn. The quest to be thoughtful, compassionate, informed, and connected should be lifelong.
So I'll tell you something that we get, or we have gotten before. We did a partnership with, I don't remember their name. It wasn't Lily. That was Vera Bradley. We were able to do a takeover for Vera Bradley. And some of the comments and that brand, I mean, I think they've tried to be a little bit more diverse, but historically they just have not been a very diverse brand. And therefore their following is not very diverse. And there were lots of comments about how color shouldn't matter and we should just be talking about breast cancer. And the goal is not to see color. In fact, not seeing color is very problematic. The goal, when you say that you don't see color, it makes it very difficult for you to appreciate the differences in other communities and to acknowledge the challenges that other communities are facing because of their color. The don'ts. So, don't be afraid of the word privilege. Oftentimes, it is people with privilege that push a movement forward that is invaluable. Certain privileges can help get underrepresented communities access or visibility in spaces they may not have had previously. See your privilege as a means to support communities instead of feeling bad about it. It's what you do with your privilege that counts. Don't wait for people, communities, or organizations to reach out to you out of the blue. Don't retreat into your privilege and abandon the work if you feel uncomfortable. Be accountable and embrace the discomfort. Don't walk away if you make a mistake. Listen, learn, pick yourself up, and move on. It's okay to make mistakes. Don't think that you know everything about another community or an issue, or talk more than the women you are standing in solidarity with. This is what is commonly called speak up, but not over. So one of the things that as an early stager and as leaders of a community for women of color, we've been challenged we want to make sure that the narrative for the metastatic breast cancer community is included in everything that we do. We do our best to do that. Our initial approach was we would see things, we'd be like, that sounds like a great idea. We want to make sure that that story is told. And it took one of our baddie ambassadors having a conversation with us to help us realize that we were wrong in our approach. So instead, the appropriate way to do this would be, let's ask our metastatic baddies what stories, what information they feel needs to be said and what stories need to be told. And we're going to share that. We're not going to like they say, we're not going to speak over them. We're going to give them a platform to speak for themselves.
Right. And there's always opportunity to learn at anywhere that you take the chance to. It just actually takes the time of listening to what's being said and then applying that to whatever you move forward.
And that's it. Did we make time? Oh my goodness, we did. So we are happy to take any questions that you all may have.
Yes. Thank you so much, Jasmine and Marissa, for a really excellent presentation. And we do have a lot of time for questions, which I know based on the chat comments that your presentation got a lot of engagement and thinking. So if you have any questions for Jasmine and Marissa, I encourage you to put them in the chat, or if you also want to unmute yourself and you can also share your video feed as well and share your question verbally as well. So thank you so much. Jasmine and Marissa, your presentation gave me again a lot of things to think about, and I'm sure our audience also a lot to think about in terms of how to integrate this both in our personal life and our breast cancer advocacy life, as well as into the organizations like Living Beyond Breast Cancer and other organizations that we're connected to. So I really appreciate that. I'm wondering, since both of you went through the Young Advocate program, if you could talk a little bit about way, I mean, you've given us some good frameworks about things to do to be a good accomplice, but kind of how would you suggest for leadership volunteers like Young Advocates and Hear My Voice advocates, how to kind of integrate some of these ideas into advocacy and outreach work? For instance, community events that our volunteers are hosting in their community, speaking events that they may be sharing their story at, or even, this is a little pre-pandemic, but if you're hosting a table at a conference or something in a health fair, how some ideas maybe, since you're so familiar with our Young Advocate program and what are some of our leadership volunteers do, maybe we could start there. Any tips you have with that?
So some of the things that we've been seeing within our Accomplice community is that people are asking the question, do you have any other women of color that are going to be part of this panel? Do you have any other women of color that are speaking? Do you have any other women of color that are going to be volunteers? And then you take that a step further, because you don't just want to throw that out there. You want to say, I have someone that I can recommend. And so we've been fielding those questions. We are happy to connect people with opportunities all the time. But that just initial conversation of just asking, do you have anyone else that represents this community? If not, I would like to recommend someone. So when you talk about the accomplice and this idea of like the risk involved, there have been women that have gone as far as saying, I will not participate unless you have a woman of color that is part of this panel, because I would rather give up my seat so that a woman of color can be part of this panel. For us, we've also shifted interviews. People would come to us for things and say, I don't think that we're a good fit for that. I think this person would be a better fit for that conversation. So again, being an accomplice is definitely about not centering yourself and understanding where there are places or cases where an opportunity may be more beneficial for a different community.
Yeah. And if you do invite them to the table to come and speak with you, definitely make sure that their voice is being heard. If you're just inviting them there so they can just, quote unquote, be a space holder and make it look like you have people of color who are on your panel and speaking, if they're not getting their story out or their opinions, there's no point in even having them there if that's the case. So definitely, like Jasmine said, asking if they're going to be other people of color that are going to be on this panelist, and then making sure that they have their own time to speak their truth and their voice and let their voice be heard.
And in the cases where maybe you're at a table and that's not the case, you don't have like other people that you can pull in. Knowing the information, to me, it's a starting point. It opens the door. So I can say that the statement that I say very frequently, even, and what I'm doing is, as an early stager, that 30% of early stagers will be diagnosed with metastatic breast cancer. That opens the conversation, and I can refer you to several other women of different races in the metastatic breast cancer community that can better speak to that. But I think sometimes our inclination is to be the mouthpiece when we really should be more amplifying than like doing the actual talking ourselves.
Right. The people who actually have the voice and they're living it right now and they understand and can experience that, can talk from that perspective more than just even Jasmine and I can.
Right. And I can imagine that idea might also extend to, if you're doing outreach in your local community, to work a little extra harder, especially if you're a white person who maybe know more white organizations, to kind of look for, as you mentioned in your remarks, are there organizations founded by women of color serving the cancer community? What are those? And maybe kind of just working a little bit harder to see if to expand your knowledge of the resources that are available, and then start networking and making those connections. Might be just comments, a thought that came to my mind. Would love to hear if that. I feel like that kind of aligns with maybe some of the physical outreach work that maybe we'll get back to doing someday after the pandemic.
Absolutely. Because what you'll find is that there are a lot of grassroots organizations that are doing the work that don't have the same resources as your American Cancer Society or as your local United Way, but they are very much so ingrained in their community. And so bringing them to your table, giving them access to your resources. I know like handing out pamphlets was a big part of what I did as a state leader for Young Survival Coalition. And that also meant that I was going to give information to people that were more prone to go into urban communities or older or younger communities or whatever the case may be. But I definitely think that you're absolutely right. Give a good understanding of what's happening in your community, being intentional about that, and understanding how your resources can benefit them.
Yeah.
So we have a number of our fabulous helpline volunteers with us tonight. So again, our helpline is providing that peer-to-peer support. I wonder if you had any comments about how to integrate some of these ideas into folks that are serving on our helpline as volunteers. So for working with callers, perhaps women of color that are calling and looking for support, and kind of how to make sure to kind of maybe integrate and address these issues in that volunteer setting.
You know, I think cultural competency, I think as time goes on, it's going to become more and more important. Being aware of your culture, how that impacts the way you view the world, but then also having an understanding of how other people's culture impacts their way of viewing the world. Unfortunately, a lot of the research shows that, especially for Black patients that have Black doctors typically report getting better treatment. When we're looking at our research about clinical trial engagement, we're also seeing that patients of color are preferring to have care providers of color. Now, the challenge with that is there aren't a lot of doctors or there aren't a lot of care providers of color. So then that's where cultural competency comes into play, and understanding how to navigate those experiences when there isn't another doctor and you are the doctor, or you are the patient, or the patient or the volunteer in this case. There may not be someone else. So I definitely think taking the time to educate yourself on other cultures is going to be a great way to help you mitigate or navigate how to better help someone that doesn't come from the same background that you do.
Yeah. And I think it's always good to even it's okay to say, I don't necessarily know the answer to that question, but I'm going to find that out for you and I'll make sure that I get back to you, instead of just, I don't know. Because then if you just say, I don't know, then you're both just kind of stuck there. But being able to reach out to other people who may know the answers to those questions about finding like a provider of color or an organization that represents people of color within that community is always helpful. So actually just digging a little bit deeper, doing your own research, and like Jasmine said, having the cultural competency and having those lists of organizations or people that they can outreach to, that you can also maybe ask questions for yourself as a volunteer.
And I think it also goes into that personal engagement. The more engaged you are with other communities, the more informed you are. So as a volunteer, that means being part of those conversations that are happening in other communities. And like we're saying, being proactive and being part of the conversation so that you have a better idea of how to navigate those experiences.
Great. And I think tonight's conversation is a great starting point, or has a lot of that infused into the presentation tonight. And just to share, Living Beyond Breast Cancer is really committing to expanding our networks and working with different organizations. And so if you're looking for those types of resources, LBBC staff can help connect you with the resources we know. We're always looking for new resources as well, and continuing to expand our knowledge base. But we do have some great connections and resources that we can help with. So we did get a question about disparities in clinical trials, which you did mention a little bit in the presentation. You had the statistics around clinical trial recruitment. Do you have any comments about kind of how to impact that and move the needle a little bit more about including more women of color in those clinical trials and the importance there?
So that's actually what our research project, our market research project, is on right now. So even though we're a blog site, we've very much so recognized the power in being a platform that captures the attention of women across so many cultures. There's never been anything quite like it. And so we have this, it's a privilege for us, right? Because now we are able to engage communities that have been overlooked and underrepresented for so long. What we are looking at in this project, what we're hoping to do is come away with some actionable things that the community can do to help move the needle from the patient perspective. Some of the things that are coming up in conversation are things like logistics. How many of how transportation can become a barrier, how when you talk about income inequality, there's a lot of talk about affordable healthcare, and I don't know if we've really gotten down to what that really means in terms of accessible healthcare. So when you think about someone could be making the same amount of money, but their job could be hourly instead of salary, when they take off work, that's a disadvantage for them, and that becomes a barrier. So I definitely think over the next couple of years, hoping to see more advocacy pieces that are a little bit more inclusive into those different holistic approaches. And for us, we're also looking at how can we teach people about clinical trials, what difference that makes, and whether or not they're willing to participate. A very interesting study that I was reading last night actually was on cancer health literacy and whether that impacted someone's willingness to participate in research. For a white population, it actually didn't sway one way or another. For the Black population, it actually did increase people's likelihood to participate in research. Well, for the Latino population, it actually decreased their likelihood, primarily because we've kind of skipped some things, right? Now that you understand what the research is, let's go back and let's talk about what my disease is and all of these things I didn't really understand because there's that language barrier. So I definitely think there's a lot of work that has to be done in improving the clinical trial representation, but I'm really hoping, and with our project, with the project that Marissa Breast Cancer Alliance is working on, that Stephanie Walker mentioned in the comments specifically about Black women, and also another project that's being done by the Touch Breast Cancer Alliance. I'm really hoping that there are some actionable items that we can use as a breast cancer community to mobilize and really make a difference. And make a difference in a way that is equitable, not equal, but equitable.
Mm-hmm.
Yeah, and I would also just add to that, if you are, a white woman or white male and you are participating or you're being approached with a clinical trial, even just asking the clinical research, person that comes up to you, ask them how many people of color do they have in this clinical trial? Have they reached out to other people of color within this clinical trial? Because I think that also jogs their memory because they just forget. And a lot of providers that we've heard from, especially just me working in healthcare, they just say, oh, well, women of color don't want to participate in clinical trials. So Jasmine and I have heard that plenty of times. And we can tell you 100% that's not true. Whenever somebody comes to us and wanting to get more women of color participating in clinical trials, we disseminate that information into our private Facebook group, and hundreds of women reply to that message. So it's not that we don't want to, we're just not giving the information. And so if we're not given the information, how are we supposed to know about these clinical trials that are happening?
Mm-hmm.
And then you also have the challenge when it comes to clinical trial representation are the criteria that it takes to be part of clinical trials. So when you have communities of color that typically have comorbidities, that's another exclusion factor. So when we talk about increasing representation, we definitely have to do a holistic approach. My feeling is that we should be more of a community of collaboration and not of competition. There could be a community that's doing a really great job, like maybe a Keep Abreast that's focused on health and fitness. Health and fitness is going to increase someone's likelihood of being able to be a part of a clinical trial if that's helping them get rid of some of those comorbidities. If we're focused on education, that's helping someone increase their health literacy, which may encourage them to participate in a clinical trial. So I definitely think there are going to be some awesome ideas that come forward in the next couple of years.
Great. And I want to call out Stephanie Walker, who posted about the project that she's a part of, Become. And Stephanie, if you want to unmute yourself and give a little plug for that, I know the survey is out or will be launching soon. So if there's any announcement you would like to share about that, it's a really exciting initiative and a survey looking at Black men and women with MBC. So putting you on the spot if you're still on the line.
Yeah, putting me on the spot. But first of all, I want to
Yes.
say thank you to for the rest of us for doing this. It's much needed, and wish it could be presented on a bigger scale to a lot of nonprofits and industry folks. But anyway, the project that I'm doing is part of the NBC Alliance, Metastatic Breast Cancer Alliance, and my project is called Become. It's a little bit different than the one that For the Rest of Us has done, and hope we can capitalize and learn from both. But my project actually is looking at why women, obviously, or Black men and women, aren't doing clinical trials. And I'm trying to reach out to those people that we don't see on Facebook every day. Those that live out in rural arid counties that have trouble with access. They're having trouble with access to care and access to internet and access to everything. And I happen to live in one of those areas now. And I'm not from this area, but I'm here. But I am, like the team said earlier, that I consider myself, my privilege is being a nurse for 40 years and being able to pick and choose where I want to get my treatment. So with metastatic breast cancer, I think that I've been blessed on that front. But the project is coming out. The survey should be, we're launching mid-May, and looking for ambassadors throughout to help get the survey out to those that don't have internet access or a little timid with using social media as well. But it will be pushed on social media. If you need more information, you can go to www.mbcalliance.org/become.
Great. Thank you so much, Stephanie. And Living Beyond Breast Cancer is, we're excited to be a partner and help support that initiative as well. So we will be connecting with all of our leadership volunteers when that survey launches, and give information about how you can help be an ambassador and help Stephanie with this project and getting it out.
Thank you so much.
Yes, awesome. Thanks for letting me put you on the spot too.
Sure.
So Jasmine might have seen the other one of the other questions. So first, the chat is full of lots of praise from our attendees tonight. Really thanking you, Jasmine and Marissa, for such a great presentation. A lot to think about. So one of the questions is how do we get in contact with you? Where can we find more information? So Jasmine, I see you put in the website for breastofus.com, and I know that you have a lot of social media. What's your recommendation for folks that want to reach out to you after this presentation?
You can do both. If you go to breastofus.com, you can actually sign up for our newsletter. We try to put whatever research things are happening. We're excited about the project that's happening with Touch and with the NBC Alliance. So you'll be hearing about that when we have our next phase of our study will be announced in our newsletter as well. And if you go to our social media, there should be some like an email button on Instagram, so you can get our email address in there, but our Instagram at For the Rest of Us on Facebook and Instagram, and then on Twitter at The Rest of Us.
Great. Thank you so much. So again, just a big thank you to both of you for this presentation. You've given us a lot to think about and a lot for us to be integrating more into our work as leadership volunteers and our leadership supporting the leadership volunteer community. So again, I'm really excited for LBBC and our leadership volunteer community to continue this conversation, to continue to work together to reduce health disparities, to reduce some of those really terrifying statistics that you shared with us today, and to be an accomplice as part of this work and really kind of working together to move the needle and make a true difference in our breast cancer community. So I want to just close today with a couple of announcements about things that are coming up with Living Beyond Breast Cancer. So as always, we always evaluate our leadership volunteer continuing education. So we'll be sending out an evaluation tomorrow. So check out your email and you'll get a quick evaluation link. It only takes you like 3 minutes to complete, but we would love to know your thoughts. What worked really well tonight, ideas you have for any future programming you would like to see for our community. Please take a moment to share that feedback with us through the evaluation tomorrow. I also want to remind everyone that Reach and Raise, our annual signature yoga fundraiser, is coming up, and we have a team specifically set aside for our leadership volunteers called our Volunteer Heroes teams. We have our co-captains this year are Katie Boudris and Brittany Shook, so members of our Young Advocate and Hear My Voice community. And last year, our team raised $10,000 as our volunteer community. So we're really excited to build on that amazing effort from last year. You should have gotten an email last week kind of with more information, but we will be holding a kickoff call for that team on April 14th. So keep an eye out for that registration link in your email and on the closed Facebook groups. Jade will be sharing that. And again, the Reach and Raise event will be held on Sunday, May 16th. So we'll all be joining virtually again for that yoga event. The other announcement is LBBC's annual metastatic breast cancer conference is coming up. It is going to be April 17th and 18th, so please go and register. We're going to have Zoom meetups this year, and we have meetups for newly diagnosed, those Black breast cancer meetup for those living with MBC, young women, everything. So including leadership volunteers. So we're really excited to be holding this program virtually again. We wish, of course, we were in person, but this conference is going to be really fantastic. And it's also, if you are don't have metastatic breast cancer, it is also a great opportunity for you to learn more about METs. So we talked a lot in this program about educating yourself outside of your own experience. So I encourage those that have been diagnosed with early stage breast cancer to take the opportunity to register for the METS conference, just to expand your own knowledge too. So I think those are all my announcements for tonight. I want to thank you all for taking time out of your busy evening to join us and learn more about this really important topic. And I want to thank Jasmine and Marissa for an excellent presentation. So thank you all.
Thank you.